the show all about the science of pre-hospital care. This is going to be episode 5 for May the 8th, 2019. And this is the pre-show. And this is a time where everybody kind of logs on and starts getting things going, making sure that all the technology is working right. And we'll go, and then we'll start around 7 o'clock. Just waiting for everybody to log on. Check 1 2, check. Check 1 2 1 2.
Hey, Mike.
Hey, Pat, how's it going, pal?
Good, buddy. You doing all right?
I'm doing good. I'm getting logged on. Sending out Paige needed an invite. So I'm sending out to her now. I think that's what I'm going to start doing, actually, just sending the invites out right before we start.
Oh, okay.
Hey, I'll be right back. I got to use some earphones.
Oh, no problem. I'll be back, too. I'm going to grab something myself.
All right.
Yeah, I haven't figured that out yet. There. How's he doing? Yeah.
There's pressure there. If you can feel how hard it is there.
Yeah.
Yeah, that would be a child. Probably a butt.
I touched the butt.
He touched the butt. And a boy's butt.
I know. Well, it's inside you, so there's a lever of safety.
Hey,
Hey,
Paige.
hey, Pat. Pat Miller.
What's up?
Not much.
Trying to get everything together to try to log on or try to get my earbuds in and all that stuff.
Yeah, you're fine. I don't think Fidel is joining us.
Did you hear from him or anything?
No, have you?
No. I've got us recording for the pre-show though, but I haven't heard from him.
Okay.
Is he off this week or?
Well, somebody said that he's been sick, so.
Oh, good.
I was trying to see how he was doing.
Okay, yeah.
Yeah, he was in the hospital, I think, for his back.
Oh, goodness.
Is it good?
My car battery died this morning.
Oh, God.
And it needed new tires. So I had to jump my car with Bennett running around.
Off the truck?
Yeah. And go spend almost $700 on new tires.
Check 1 2 1 2 check.
And then get a new battery. But I'm doing that in the morning. And then my shoes broke, my other shoes.
So you broke your flip-flops?
Yep. Broke my flip-flops.
You have like 8,000 pairs of flip-flops.
Still.
I own
I broke my shoes this morning.
no pairs of flip-flops.
Well, Flip flops are pretty much all my feet fit in right now. So
Yeah,
They're not that swollen.
Yeah.
Okay.
they're swollen. It's okay.
I can see.
Let's
It's
try
not the only thing that's swollen.
Oh, no,
Look,
fine.
There's a reason this happened.
I know why it happened.
I'm pretty sure I do too.
Like 1, 2, 1, 2, check.
You willed it to happen.
I did a thing.
Right. Kaylee, it's Kaylee, right?
Yep.
Well, we appreciate you being here and sharing your Wednesday with us. You're too kind. Thank you.
Oh, I only do
Yes,
it for
thank
the
you, Kaylee. We
rewards.
That's what I heard.
The
Some
free
people will
coffee.
do anything for Starbucks coffee.
I will do anything for coffee.
That's
It doesn't
what I
even have
heard.
to be Starbucks. How do you think this happened?
Oh, that's good stuff.
Oh yeah,
That's
it was
good
even
stuff.
funnier with our first class when she came to teach them OBGYN stuff. When she's like, "This is what it looks like. She's pregnant already."
Yeah.
So if we can get her to come back for the next class, you'll be at what? 40.
Oh,
You'll be
yeah.
at what,
We're looking
35
forward to having you back
When are you coming?
to do the
Early July.
OBGYN thing.
in
Yeah.
June.
I will be ready to pop. You might get a live demonstration.
No, that's not true.
Nothing's too good for our students at the Cobb County Fire Rescue. You know?
A friend of mine teaches childbirth education and went into labor in the middle of one of her classes
Oh, wow.
over at the cab. So
Oh,
her water
my
broke. She finished out her class and then went and delivered her baby.
Nice.
Wow.
Who's the doctor?
That's
Not the cab.
dedication right there.
Nope, not the cab.
Not Durant.
No. She would have had a C-section if it was Duran.
Nice.
Ugh.
So the goal one day is to, put these out on there. A couple different websites out there for folks who want to see it and stuff, but not really to put the pre-show out, but just to put the regular show.
You mean
I
with
like
our
the
intro
part-
theme music?
Yeah, I need some bumper music, by the way. And Pat, I got us an email address for the show now. Paige.
Oh, wow. I saw the logo.
Yeah, it's fancy.
Who
Yeah,
did
we're
Paige did the
getting
logo.
serious.
Paige
We didn't
actually
have
did the
a
email
logo.
address.
Do you have a copy of the logo available, or do I have to figure out if I can pull it up?
I love the. Yeah,
You know
you need
what?
to
Let me see.
put
Stand
it on
by.
t-shirts and stuff.
I will see what I can do with that.
God, it's hilarious. Let's see if I can.
Let's see here.
Did you talk about my stroke the other night?
The guy who went out on top.
Yeah.
Okay.
He's had no neuro deficits.
Oh, that's good.
Mm-hmm.
I think I can pull this up here.
Love it. Love it.
That's what happens when I get bored sitting in front of my computer in paint.
Okay, that's how you know you're a dino if you used paint.
There's nothing wrong with using Microsoft Paint.
It's like playing Minesweeper when you're bored.
Yeah. Well, it's not me.
Oh, that'd be my neighbor.
That is hilarious.
Oh.
There we go.
There you go.
So we don't have Fidel, but we've got everybody. You want to get started?
Sure.
Pat?
Hey, I'm ready.
Bedtime's early.
Yes,
All right,
bedtime
then.
is early.
Well, yeah. What'd you say, Paige? I'm
We
sorry.
have a 2-year-old. Bedtime comes early.
Yeah, man, you ain't joking. You ain't joking. So, all right then. So,
Time to get old.
It's like 8 o'clock at my house.
mm,
That's because all
yeah,
y'all can get up
it's like
early.
around 9 o'clock here. I try to get into bed about 9.
Well, my husband leaves for work at 5
Yeah.
and does his 12. And then the baby wakes up at like 7.
Yeah.
And then I get him to daycare and do my stuff and then go to sleep so I can be at work at 7.
Okay.
So you gotta work tomorrow night. Ugh.
Or Thursday, Friday, Sunday night.
Thursday, Friday, Sunday.
Mhm.
And let's do it. You gotta work Mother's Day.
Yeah, but it's overtime pay.
Okay.
And overtime pay on a weekend diff. Weekend night diff. It's like $7 an hour extra.
Okay.
Plus
Yeah.
overtime.
Okay. Yeah.
So
I
it's
do
like
too.
$60 an hour.
Wow. All right, let's get started in 5, 4, 3, 2, 1. Welcome to the show all about the science of pre-hospital care. Welcome to Dino-Brains, episode number 5 for May 8th, 2019. It's going to be a special show tonight because it's Nurse or Healthcare Appreciation Week. And we have a visitor that works actually in the emergency department that's going to kind of hang out with us tonight. And I'll turn the show over here in a second to Paige to let her introduce our special guest. We're missing Fidel this week. He could not make it, but we hope to have him back next week. But I see Pat Miller is here. Pat, how are you?
Good, Mike. Happy to be here.
Good. Anything going on this week?
Not a whole lot. Today we had a demo for the King Vision video laryngoscope, and so we got to look at that, play with that a little bit. Had some fun with that.
I've seen you down on our floor today doing that stuff.
Yes.
Yeah,
Came down to the where the education is abundant. And, got some education on video laryngoscopy.
Are we possibly going to get that? Because they've been there a lot, showing it off.
Yeah, it's I think it's something the department's really interested in. At least we looked at the King Vision, and then last week we actually looked at one called the Air Track that is very similar. It's also a video laryngoscope, and I hope we do. I think it'll add another element to pre-hospital airway management.
Yeah, that would be awesome. So, Paige, why don't you take over from here and introduce us to our special guest tonight?
All right, I can do that. So obviously this is Nurses Week, so I figured it'd be a good idea to introduce a nurse since we talk about all kinds of pre-hospital stuff. It's not just us in healthcare that deal with patients. We take them to hospitals and have them get care and treatment and hopefully released from the emergency room when they don't actually need further care. And if they do, well, then they stay at the hospital. So nurses are the most vital part of that. Without them, nothing would get done. Doctors treat, they diagnose. The nurses are the ones who give the medications and do all the day-to-day activities. So without them, we couldn't do anything. So who we have here is Kaylee. She's a nurse here for Piedmont Healthcare out here in Walton County. And she's also a current OB nurse.
No, former OB nurse.
See?
Current paramedic.
And also paramedic. So that's how I know her. So she understands both sides of this. And she can give us a little insight into what it's like, differences and similarities there are between not just paramedicine, but emergency medicine, pre-hospital, and in the hospital. So, yay!
Welcome, Kaylee.
Thank you.
We're glad to have you.
Yeah, happy to have you.
Yeah.
Thank you.
I know I have 1,000 questions. So
All right, go for it.
go for it. All right. Excellent. So we get some of the stuff maybe answered that everybody kind of wonders about. First of all, if you were not going to be a nurse, what would you have been?
Well, I probably would have just stayed as a paramedic if nursing wasn't an option. I
Okay.
wouldn't have left healthcare.
Okay. So you've known
I
right
just
away.
didn't want to go into the admin side of EMS. So to keep going, I decided to go to nursing school.
Okay. So you've known for a long time that since maybe you're smaller, this was the field for you, right?
For about 10 years
Okay.
when I got into it. Yeah.
Okay. So exactly what maybe in the emergency department when we bring a patient in, maybe a STEMI patient or maybe a patient who's maybe sick. What exactly? We have the report. We give you guys a verbal report of what's going on with the patient. What are some of the things that you would want to hear in a report from EMS?
It even goes back to before you guys even arrive. If we can get a really good report that gives us a pretty clear picture of what's going on with the patient before you even get there, we can have the things on our end that we need already assembled. So if we know that they're having a respiratory problem or a difficulty breathing, we can have respiratory therapy at the bedside. We can have the vent already ready to go or an RSI kit if they're going to need to be intubated. We can have it in the room and prevent a delay of care. So the first thing on the EMS side is just giving a really clear report of what's going on with the patient. And it may not necessarily be super clinical terms. I've called in reports before on the ambulance. This guy is not breathing. You need a team there, something like that. And that just lets us know on the hospital side, we need to have these resources available immediately. So that's really the most important thing that we're looking for. Just a really clear picture before you even arrive of what we're getting.
Yeah, I think that, and I think that's a small problem that we face here in the pre-hospital setting. I know right before I came to training, I actually was riding in with AMR, and we had a patient who was in moderate to severe distress, and I heard the paramedic that I was riding in with called in the report, and I said, "You're going to have to call them back. They're from your report, they're not expecting a moderate to severe respiratory distress patient. Right now, they're just, they're expecting the normal patient. We need to call them back." And I don't think that's just, that one paramedic's problem. I think that's a lot of the problems really in our field is that we don't explain that well enough. So I agree in that the pre-setting. I noticed too when EMS patients come into the ED, let's say a cardiac arrest patient, there's a couple things that I like to hear. And I don't know about you, but I like to hear one, how long have you been working this patient? Not really a guess. I mean, we were on the scene at 6:30 p.m. We've been working them now for an hour. Also, because that kind of gives us an idea, right, of how long this patient's been down.
Using your dispatch times, even if you have to say, "Give me just a second, let me clarify with dispatch," that tells us a bigger picture. And another really big thing in the hospital is telling us the things that you saw on scene or in transport that we're not going to have a clue about. Did this patient who's now got a massive fever come from a house that had no air conditioning and no electricity, and there's all kinds of other social stuff that we would have no clue except your eyes. So the pre-hospital setting or the pre-hospital treatment really expands what we can do if you guys can just tell us what we're missing.
Sure. I totally agree. What about STEMI care? I know you work at Walton right now, and I'm not too familiar with it out there as far as STEMI care goes, but I'm sure you being a nurse, you probably worked in other places besides Walton, maybe. How's that going? As far as I don't know. I know for me personally, I think STEMI care when it first came out, it was aggressive, and I would call in a STEMI patient, and if I didn't go to the cath lab, I was lined up for the cath lab. And in today's setting now, if that 12 lead's not transmitted and that physician doesn't have it, a lot of times they won't call a STEMI alert in certain hospitals. I don't know about where you work, but I was wondering, could you tell us a little bit about that?
So the hospital that I work at actually doesn't have a cath lab. We're considered a community resource hospital. So we do get STEMI patients from EMS. Unfortunately, part of the problem I think is STEMI recognition, and it's not pushed as much as it used to be. When I went through paramedic school, it wasn't pushed, and I really had to look for outside resources to teach me more about STEMI recognition. And I'm seeing it in some of the other agencies and other hospital settings that it's not recognized, or if it's not sent and the physician doesn't see it, they don't have the same trust that we used to have in EMS, unfortunately. So being able to transmit an EKG or take a picture of it and texting it to one of the nurses at the hospital, something to get it looked at beforehand, saves your patient time and getting them to the appropriate facility. So taking them to me, if you recognize a STEMI, is not appropriate because that's delaying their care to a cath lab. Whereas if you take them to a hospital that has one, you're doing the best thing for your patient.
Sure. How do you feel about, in EMS, and you're perfect for this, actually. In EMS, we have protocols just about for everything. A protocol for giving Zofran. We have a protocol for cardioversion. Do you guys have similar protocols out there as a nurse?
We have, they're not quite the same that we're thinking of as protocols. So for you guys with the protocols, it's everything from what medications you can give and what indications for those meds and the doses and everything. Right. For us, it's if we're starting a protocol, it's for a chief complaint like abdominal pain, and I'm going to go ahead and order these labs and get these tests rolling. So it's not so much the treatment. For us, our protocols are more getting things started while the physician takes a look at everything and they could put in orders for medications or scans or whatever.
We had a meeting a while back, and one of the things we were talking about was patient dissatisfaction. You have some triage nurses who will, if the patient's having nausea, vomiting, they'll throw in the Zofran. You have some that if the patient arrives in the room and they're in severe pain and they realize the ER is busy, it's going to be a while for the physician to get there, they'll throw in 4 milligrams of morphine.
Right.
And you being a paramedic, that most protocols, a paramedic can give up to mostly up 10 milligrams of morphine. So 4 milligrams is appropriate. How do you guys feel about that kind of thing working in the ED, and how do nurses feel about that?
Personally, I think it's great. If my patient comes in already kind of happy because they feel like their complaint has been addressed or that what's bothering them has been heard, that makes it easier for me because they've told the medic things. That medic is relaying their history to me correctly. The patient is agreeing or adding on to it. Sometimes, sometimes they come in and say the complete opposite. But if they feel that they're being treated by everybody involved in their care, they're going to be happier. And a happier patient makes my job easier because they're going to be more honest with me if they're happy with me.
Right.
Yeah.
Yeah, I didn't know. I know some nurses I talked to said, I'm not putting anything in till the physician sees the patient. And then I know some are like, yeah, I'm treating this patient for what's going on,
Yeah.
And
sometimes it just depends on what physician you have. Some of our doctors are absolutely happy that we put in protocols. Some of them are absolutely against it. So that plays a part in it. And what you're allowed to do within your protocols plays a big part in it. What my protocols are different than what the CABS nurses have, and it's different than what Gwinnett's nurses have. So it's,
yeah, that's what I was wondering about. I just thought it was strange that, I've known, our protocols at a CAB that I can speak for, I'm familiar with, that we can give a lot of narcotics, and an ED nurse can too, if they choose to, but then there's the little conflict about who's the physician. And I just find it strange about that in a way, because, you're so aggressive in the field, and then in an ED department, I was just wondering, have you ever had a physician question you about giving such a small amount, 4 milligrams of morphine?
Yes. I've had physicians question me coming from the truck and coming from the nursing side. You know, I had a
Right.
patient, for instance, on the ambulance with an obviously dislocated shoulder, and they questioned my fentanyl.
Wow.
And I said, well, if your shoulder was out of place, you'd want fentanyl too.
Sure you would. Sure you would.
You know, so
Yeah.
the big thing is advocating for your patient. Do the right thing by your
Absolutely.
patient, and
And
who cares
that
what the
is
doctor thinks.
absolutely correct. And not just advocate here, a nurse is talking about advocating for a patient in the ER. And you're right. And from the pre-hospital care, you know, a lot of times, and that's kind of how I've judged my treatment over the years, not so much by protocol adherence, but by putting the patient first. If it was good for the patient, if I felt like that's what needed to be done, and I could explain it somewhat intelligently, and putting that patient first, it's hard to argue against that.
It's kind of interesting that we go down that topic. I had a patient recently that EMS brought in with a blood sugar of 18.
Wow.
I've never seen somebody that low and alive.
Yeah.
And they did not administer any medications because their protocols say they have to give IV attempts they have to do 3 IV attempts before they can go to anything else, before they can do glucagon, before they can drill, before anything. And that patient was suffering neurological damage each minute that their sugar was that low, and it continued to drop. So was doing the right thing by the protocol the best? Absolutely not. Doing
Right.
IM glucagon or drilling that patient and pushing D50 would have been more appropriate. Ask forgiveness later because your patient's alive.
Right.
So,
I like that. Yeah.
I'm kind of hogging the floor. I'm,
Oh no.
I love it. Okay, Pat, jump on in here.
Kelly, I did have a question for you.
mhm.
Well, and you guys will remember this, you being in EMS and everything. So back in the day, somebody asked me this the other day. I had no idea.
Mhm.
You know, back in the day, we had paper PCRs, and we would come in, and the nurse would sign, and we'd rip off a copy. Here you go. And then at DeKalb for years, we actually had printers at all the hospitals in Metro Atlanta, and we went to the tablets, and we had ePCRs. We would print off our report, give a copy. We don't do that anymore.
No.
You know, now we're just using the tablets. And then when we're done with the report, we post it and it goes in a cloud, whatever that is. I don't know. But I guess my question is how do the nurses extract that information? Are you able to, or is it easy? I don't even know if you do. Or if
It's
you're
not.
able to.
It's not easy. And honestly, it's not my favorite thing because when I started EMS, we had paper PCRs and we couldn't clear our call until our PCR was done. It's part of your patient handoff.
Right.
And now, because I'm still technically employed by an EMS agency, we have the tablets and we send it off to the cloud, but that makes it so much easier to go back in service before your report is done. And if you're doing that, which unfortunately I think just with how busy services are, especially in Metro Atlanta, you're going back in service before your PCR is done, and then the hospital doesn't have it. So you may have forgot to mention, oh, I did XYZ, and then we're going to turn around and do the same thing. Or, you know, you may have forgot to mention that you ended up giving a second dose of Narcan. Well, now we're given 4, 5, 6 doses, and it's not helping the patient. They're obviously not in a narcotic overdose. It's kind of delaying care or doubling up resources when it wasn't necessary. Whereas if we just had that documentation, I could look back on it and say, oh, this is what EMS did. So we don't need to do this because EMS already did it. So
well, Haley, how do you access our piece? Like, is there this? I'm not a technology guy. Is there like this big, huge cloud with millions of EMS
I don't
reports?
I don't get them. Our secretary at some point in the night pulls them from the last 24 hours and sends them off to medical records for them to be attached to the chart. So it's not a part of their EMS or their ER care anymore, whereas it should be.
Right.
I completely disagree with the delaying PCRs and them not being accessible by the nurses because I'm missing things. And it's unfortunate.
Do you think
that makes
because
sense.
that you're not getting the PCRs right away or within a reasonable amount of time, it actually puts an animosity, like you feel like EMS may be lying to you about it and they're trying to hide things? Or that maybe you're just not getting all the information and that there's a confusion later with patient care?
For me, sometimes it's more of a confusion later. And I think that's because I come from the EMS side where, you know, if I messed up on the truck, I was honest about it. Like, hey, I did this and I really should have done something different. I'm sorry, but you know, it is what it is.
Yeah.
I don't think medics are hiding things at all. But some of the nurses that have no ER or EMS experience or look at everybody as an ambulance driver may feel that way.
Okay.
I can't really speak for them. For me, coming from that side, I don't think that our medics are hiding anything.
Yeah.
Do you think at some point during nursing orientation for a hospital, say nurses residency, for nurses who've never been in the EMS service, for them to go on ride-alongs
Yep.
with ambulance services?
No question about it.
Does anybody do that you know of? I do not. I don't know. Gwinnett doesn't. I don't believe DeKalb Medical does. Obviously, I don't believe
I
Piedmont
think Grady
does.
makes their nurses
Okay.
do ride-alongs.
That would be, yeah.
That's a big deal. I think it would absolutely be a wonderful thing for new ER nurses who have no EMS experience to go ride along a couple shifts and make them do the full 24 so they can understand when I bring in a patient at 4 a.m. and I say, you know what, I just couldn't do it. I just could not handle the puking tonight or something. They can understand when you've been up for 18 plus hours and not had a chance to eat that sometimes that's just what happens.
Mhm.
But on the same token, I think every medic should have to spend a couple shifts in the ER so they can understand when we're, you know, busy sitting there doing something and not addressing you right immediately away. It's not because we're trying to be rude, but it's because if I don't remember to chart this right now, I'm going to forget. And then I'm going to have missing parts on my chart. And now I'm going to get called back into the office later. So I think it would help relations more than anything, just to have everybody know where the other side's coming from.
Do you think the
Oh
relation?
yeah.
Go ahead, Pat.
Oh no, go ahead. I was just agreeing. I totally think.
Do you think the relation between EMS and nursing? Because I know in the past with people, like I could call them up, and be like, "Hey," especially Annie down at the CAB-ER, be like, "Hey, I've got this coming on. Can you help me out? I know y'all are getting slammed, but you know we're losing them really fast." And she's like, "All right, come on." Versus now, where it's a little bit different, where you think there's maybe a little bit more of that gap that's occurred over time, where we have a lot of younger generation EMS people, and not saying nurses are getting older, but there is that gap there in nursing where they're either very experienced, we'll go with that, or they're very inexperienced. And then, you know, the nurses that are experienced remember EMS the way it was versus new EMS, and new nurses only know what's currently going on.
Yeah, when I started 10 years ago, even, it was a much different environment and relationship between EMS and the hospital, where EMS practically lived at the hospital because they would hang out with us. They would help us out with the patient until we could get them stabilized. And unfortunately, I think due to some services requiring you to be back in service immediately or just call volume, all those things, it makes it harder for EMS to stay and really get to know us. And it's not like we can leave and get to know you guys. So anything really to help that relationship, I think, would help patient care. I don't have that answer necessarily, but if we could improve the EMS ER relationship, I think it would really improve patient care.
I agree. Yeah, absolutely.
So most of the emergency departments around are stroke certified. So meaning you can administer TPA to stroke patients. But we're learning now that you know, large emboli, large clots in the brain that doesn't respond to TPA. And so I wanted to kind of get you to kind of let everybody know, maybe if you receive an EMS patient out there at Walton, maybe, and it's a stroke, it's non-hemorrhagic, patient is brought in by EMS, about how long does it take for your department to get this patient in into the ER and then transferred out to maybe Emory or somewhere like that?
So funny you asked that, because last shift that I worked, we had 2 stroke patients come in, 2 neuro alerts at the same time, both exhibiting very obvious CBA symptoms. We were able to, because they both came in EMS, and we are a stroke center, able to get them directly to CT, from the EMS stretcher onto the CT table. So they weren't even registered yet before we got them on the table. And by the time that EMS could finish giving me the report in the room, within 5 minutes of their arrival, I knew whether or not my patient was hemorrhagic or ischemic. And my patient was hemorrhagic, so we knew we weren't going to give TPA, but we already had it mixed up. So the really, really cool thing about improving these neuro alerts from EMS and having them called in and ready to go on the stretcher, ready to go on CT and everything, is I can start giving TPA. And even if it is a large clot, we're still going to give the TPA and send them out. So I can get them in and out of our department in less than an hour with TPA started.
That's good.
This one, mine that was hemorrhagic, he had a ruptured aneurysm. We had him in the helicopter within 30 minutes.
Wow.
We didn't know where he was going, but we had the helicopter on the ground, and then we got an accepting physician. So some of that falls on the hospital side too, is going ahead and getting transport ready. If we can fly him, we're going to fly him. We flew this patient to Emory, so he was in the OR within an hour of being on the CT table, because we went off of what EMS said, trusted that this was a neuro alert. I didn't stop to check to see if this patient was having symptoms. I just trusted EMS.
That's
because
nice.
There's no reason not to. It's, if anything, an unnecessary scan.
Right.
Yeah,
and that's great, because I know some at some facilities, a neuro alert is called, and the physician wants to talk to the patient, assess for 5 or 10 minutes, and then go to the scanner. So that's pretty good.
The physician can do that en route to the CT. If they want to talk to him, they can talk to him walking down the hall. Right. There's no reason, and that's our protocol, is if the doctor wants to talk to him, they can talk to him walking down the hall, or they can put on lead and talk to him in the scanner. There's no reason to delay that for a physician to, I'm going to be politically correct here, for a physician to do their full assessment.
There you go. That's a good way to put that.
Just in case.
Good way to put that. So I think that would make a good show topic, actually, one day, to look at the new neuroscience and the new things that are going on with all the new TPA studies that are out there, to really look at that. I know, well, Pat, you've seen some of it, right? Because some of that's going on in the new protocols, maybe?
Yeah. Yes. I'm one thing that I just fell in love with was the VAN assessment, visual aphasia neglect assessment, and that's a fairly new neuro assessment. And it's really friendly for EMS because there's no scoring system really. It's kind of a yes/no thing, and you can rapidly do it. It's easy to remember, and that's what I like about it. It's because it's easy to remember. And you can quickly do that and kind of figure out, is this a large vessel occlusion? And do we need to be going to a comprehensive stroke center? And that's the other thing. We only have 4 comprehensive stroke centers in the whole state.
Wow.
And we're blessed because at DeKalb, one of them's Grady and one of them is Emory, Maine. And so we've got 2 in Metro Atlanta. The other ones, I think, is Augusta, maybe.
Yeah,
I can't remember.
Augusta and Kennestone.
Kennestone, yep.
And was the other one Augusta, Paige? Was that right?
What now?
But was the other one Augusta? The 4th one?
Yeah.
Or was that? I can't remember.
I think it's MCG in Augusta.
It's Doctors Hospital.
Is it Doctors?
It's Doctors Hospital.
They're all doctors now. Sorry, but I don't think Macon currently has one, but I think they're working on it.
Macon has a burn center.
Okay.
But it's not as
still
good as
Augusta.
Yeah.
But so we fly hours, depending on what's going on, depending on the size of the occlusion. We can fly hours. Obviously, we try to keep them in system. So we'll fly them to Athens, or even potentially to Atlanta, just depending on what they need. But mine, that was the aneurysm, because he needed surgery, he needed an interventional neurologist, he went to Emory. So that's the really cool thing too about if you're in a facility that has a helipad, you're really open to whoever will accept them.
Right.
The first hospital will accept them and say, just send them, we'll get them a bed when they get here. It's really cool to see the all the different facilities working together to do that.
Yeah, that is good. Kaylee, let me ask you this. This is kind of a, I don't know, y'all probably, I'm sure you do experience this, especially in the summer months when it gets really, really busy in the ER. One thing that hurts our system as a whole is wall times. We just have and we don't even have, I guess, being on the, we have a private ambulance contractor now that, does most of our transports into DeKalb. We have American Medical Response. And that's what, ties them up a lot, is they, in the Atlanta hospitals, it's like, I don't know what to do. What can we do about it? I mean, it's just really, really busy and they don't really have a choice.
Grady's actually doing a really cool thing now, where they can transport patients to Grady-owned urgent care facilities. For psychiatric patients, they have psychiatric nurses that respond to those calls, and they can divert a lot of the non-critical patients away from the ER to more appropriate facilities. Or the facility, or the service, that I worked for has community paramedicine that's preventing a lot of these repeat callers, because they're getting their daily medications on time, and they're getting some of that in-home health that they need if they don't qualify for home health care. So a lot of that unfortunately falls on EMS to consider other alternatives, work out agreements where you can take patients to facilities that aren't emergency departments, or work out agreements where you have community paramedicine or community nurses to prevent some of these frequent flyers. You're not going to prevent every unnecessary transport, but if you can address some of those that can be addressed, there's not really a reason not to. It saves money for the hospital systems. It saves money for the EMS systems, and it provides better patient care.
Yeah.
That would be my, my starting point. The other on us, on the nursing side, with education. Is it appropriate to call an ambulance at 2 a.m. for toe pain? Absolutely not, unless your toe came off. Should you drive yourself to the hospital having chest pain? Absolutely not, because then you're going to cause a massive wreck on 285, and now you've tied up 5 ambulances, when if you just called one, you'd only tied up the one. So some of that really falls on us, educating when it's appropriate to come to the ER, when it's appropriate to call 911, and when it's not.
Right. Thank you for that. That's good.
Yeah, that was a
I
great
like
answer.
that.
That was a great answer. I think they need, I think they need to do like a social psychological, what they call it, social psychologist, to
some kind of fancy name.
Yeah, to look into why people do that. Call for that kind of stuff. I mean, I get it. Don't get me wrong. I mean, you need, there's a lot of times when it's a diabetic. I get it, but there's a lot of times when there's none of that applies.
Right.
And how we can educate that part of the public better. I think it's so over my understanding to try to identify how to, I know education and Pat knows this too. When we used to be partners, and the cab at one point in time was big on educating the public. When we had that treat no transport policy, to educate, this is appropriate for an ambulance, or this is not appropriate for an ambulance, or, and that sort of thing. But sometimes it's hard to educate people who don't want to be educated. They just want to go to the hospital, and not every person is as you know is cut out to try to educate like that, and those because it's educating, but it's a high stressful education time really when it can become confrontational very easily because the patient looks at you like you don't want to take them to the hospital, not so much as as a system as a whole. They don't understand that. They don't understand what NAT means, no available transports. They don't understand,
Yeah.
How our system works. This might have been the first time they've called, and they called for something ridiculous, but at the same time they called. And it's hard to educate that. And I think it would be great if we could have someone, a social scientist or social psychologist come in and look at that and teach us how to better educate.
One of the, I guess, best things that I was ever told right at the very beginning of my career was it may not be my emergency, but it's theirs.
Absolutely.
And if we keep that kind of at the beginning of our thought process, no, this isn't an emergency, but to them it was.
Right.
And let's take care of the situation now and address this and then educate when it's appropriate. Sometimes that 3 a.m. toe pain call, it's not appropriate to educate them then, even if it is a complete crap call.
Right.
Because they're not in the place where they can hear it.
Right.
So it's hard on the EMS system and it's hard on the hospital system, but
sure it is.
There's a lot more than just they wanted an ambulance because they wanted a free ride. That's most of the time not actually what's happening.
Right. Absolutely.
Yeah. Yeah, that's very true.
So speaking of education and obviously trying not to tie up units in emergency rooms and increase wall times, what is your opinion on nurse practitioner units and paramedics on ambulances going out to people and writing prescriptions or stitching them up or handling smaller emergencies that can be handled without massive amounts of equipment?
That would be fantastic. Grady does it
Clayton,
for their psych patients.
Yeah.
But to do some of these not quite emergency calls, but they do need treatment of some kind.
Yeah.
Yeah, that'd be great. Is it always feasible? No. But in a bigger system like the cab, it'd be awesome. It would be very, very interesting to see the numbers of how many calls a day could be handled by a nurse practitioner and a medic who can go up there, clean you up, pick you up, and send you on your way to the store with a prescription for an antibiotic. It'd be very interesting. And I think worthwhile for a system to look at the cost of a nurse practitioner versus the cost of all these unreimbursed transports.
It would be interesting. Well, we need to reach out to Chief Grimaldi out in Clayton and see if we can get him on one night. They do it out of Clayton.
Oh, yeah. Yeah.
It would be fascinating to hear how that system works. But, sorry.
Get Tracy to tell us.
Yeah.
Let's see here. What else can we talk about? And I'm going to keep bringing this up because this is the big thing. And I think you've actually had this discussion before, is education in paramedicine, where there's this push of talking about going to that associate level. And there's two sides of it. One is we're going to increase the education for paramedics. I believe it's a wonderful thing where they have to take the anatomies and physiology, pathophysiology semester, microbiology, the math, and the one English course. And I believe there's an elective humanities that has to go with that. On the flip side of that is by requiring that to go to paramedic school, they're literally only 3 other classes away from going into nursing. Do you see this? Do you think would we be able to retain paramedics, or they would go, why would I stay here when I can make 20 grand more as a nurse and not need much more education?
The medics that are going to look at it and say it's only a couple classes away are the ones that are going to go anyway.
Yeah.
So giving them, the extra boost may actually boost your medics. They may not stay long term, but you'll have them for a couple years while they're working through nursing school, and they'll make better nurses because they have all of this pre-hospital experience and years at that point of experience in patient care. So I think requiring an associate's degree is awesome on several different points. One, it makes for better paramedics. If you know why something is happening to a patient, you can address it better. If you know what's going on maybe not necessarily all the way to the cellular level, but if a patient tells you, I'm anything, their symptoms, and you can think physiologically what's going on with this patient, it may not be what it looks like at first. Your belly pain may not be a belly pain. It may actually be a cardiac thing. But if you don't have that physiology to understand that that can happen, you may miss the complete portion of your assessment. So it makes for better medics, and it makes for better nurses. But it also goes back to improving relationships, because I know a lot of the nurses think that medics just don't have the education, or they're just not smart enough, or for whatever reason,
Or that we can't read.
Or, well, if you saw some of your reports, you might understand why you think that. That goes into requiring the English class. That is important. If you could go up to a nurse and say, I have the same degree as you, my specialty is just pre-hospital, they're going to go, you know what, you're right. And I say that to nurses all the time. As a medic, I'm required to have more continuing education hours than you are.
Right. That's true.
And they go, oh, we didn't know that.
Yeah.
But if you can go and say, we're on the same page, that just improves things.
Yeah, because there's a big push for parity between paramedicine and nursing across as that type of provider. Obviously, paramedicine is pre-hospital, and nursing has a multitude of specialties, not just emergency, but intensive care and cardiology and med surge. And
if you can think of it, it's a specialty.
Yeah. And when in paramedicine, there's really just paramedicine, critical care, and then there's just a few things here or there, and it's not much beyond that. That's all you can do pre-hospitally.
Kaylee, how far is it from being an RN, BSN to being a nurse practitioner? Is that a master's degree, or how much more?
Currently in Georgia, you are required to have a master's degree in nurse practitioner, or a master's degree as a nurse practitioner. You can get a master's degree in nursing in several different specialties, and not all of them enable you to practice as a nurse practitioner. So it's another 2 or 3 years of intense classes, or you can space it out to like 5 years to get the master's. And then you have to go and take another licensing test. And you're required to maintain another license. So as a nurse practitioner, you're required to maintain your nursing license and a nurse practitioner license. And it's different continuing education. But the big push now is requiring nurse practitioners to actually have a doctorate. So they're doctors of nurse practice. So other states are starting to do that. Georgia's looking into it. I don't know how I feel about that quite yet, but it's much different than the difference between EMT and paramedic. So that I would take more to the difference between an LPN and an RN is very much the difference between an EMT and a medic. It's kind of the same.
Right.
So would they require PAs to get a doctorate?
PAs work under a different license. So in Georgia, a nurse practitioner doesn't have to work under a physician. A physician's assistant has to.
Okay.
So it's a different structure. We just see them a lot in the same type of setting. So outside of the emergency room, where you see PAs a lot, outside of that, a PA truly is working for a physician. Your ortho PAs aren't doing the surgeries, but they're prepping patients for surgery, or they're evaluating them beforehand and reporting it off to a doctor. One of my best friends is a nurse practitioner, and she consults with the doctor if she's got a question about things, but a doctor doesn't have to check off behind her. A different structure.
The only thing the doctor has to do is sign for the narcotics over nurse practice. Because the nurse practitioner sign in this state? I know some of them do allow it in other states, but
some states allow it. Georgia, I think, does not.
Okay.
But after you have a certain amount of time with whatever physicians you're working with for controlled substances, and this is the only time that this applies for controlled substances, then you have the physician's licensing number and everything to sign behind you. Some, they start to trust you, and we find this in EMS too. They trust you, and they're going to go ahead and sign whatever you do.
Right.
Whereas PAs cannot write narcotics in any state without a physician to sign behind them.
Gotcha.
So.
Okay.
Gotcha.
Other than that, a nurse practitioner can write any prescription that they feel is necessary.
Okay. I knew there was a prescription writing different. I wasn't sure
Yeah.
what level it was.
What about the
Anybody
residency
else?
program for a new nurse? What's the typical length of time that a nurse participates in this residency program after they become a nurse, and what kind of things, how does that work?
So it's different in each system, and the residency is a fairly new concept in nursing, and not every system does it. So typically it's 6 months of a real probationary period where you're in classes every week that have to do with your specialty, and you're working directly under a preceptor. Every shift, every day, you're with this preceptor. Not every system does this, and not every specialty does the full 6 months. So some specialties like med surg, it was like 12 weeks at another system that I don't work at now. It was like 12 weeks, and then the nurse was on their own taking patients, and they didn't have to go to classes anymore. Whereas if you were in like OR or ICU or critical care, you had to do the full 6 months. When I transitioned back from labor and delivery to the ER, they considered all my paramedic experience and said, well, let's just see where you're starting at, and adjusted my probation to, what I needed rather than a set time frame, which I think really is more appropriate anyway. So typically you can expect anywhere from 12 weeks to 6 months in residency, and then usually the nurse resident has signed a 2-year contract where they're required to stay in their specialty at that facility for 2 years before they can go do something else.
And can you compare that to maybe what it's like to become a new paramedic?
I got 3 upgrade rides.
Yeah, you may ride.
I got 3
shifts
upgrade
or
rides
something.
with my partner, who was a shift supervisor.
Mhm.
So that's what I did.
Kick it to the curb, Felicia.
That being said,
Yeah.
the big difference there is the clinicals in paramedic are a lot more valuable than the clinicals in nursing school. If our nurses had to do clinicals like paramedics do, we would have better nurses right out of the gate.
Wow.
I did my paramedic clinicals all on the same shift with the same 2 medics on the same truck. So I really got a really, really good Fire-EMS experience. It was with Gwinnett County, and 2 instructors, one of whom was a paramedic instructor at their academy, and one who's been a medic for probably could have delivered me as a baby. He's been a medic a long time.
Wow.
And
Me. Wow.
getting with the same instructors all the time. When it was time for me to do my team leads, I was expected to be the team lead. I wasn't expected to show them what I knew and then go do it. They knew me. They expected a certain level out of me. So when I went to registry, when I went onto the truck, I was already functioning as a medic. I knew what I needed to do because I had a really good experience. On the nursing side, that was never the case. Even in a practicum where you're expected to really get into a specialty and really learn, there was never a level of expectation to be ready to go on day one. So yeah, I think that's part of the difference. Our residents are coming in as nurses, not really having experience in patient care other than shadowing a nurse, whereas medics are coming out of school expected to be ready to go.
Right. I still think though that I think that part of our profession suffers a lot. One, you might ride a few shifts, and I agree with you. Yeah, I think when you come out of paramedic school, if you get lucky enough and you're with some good preceptors, you're ready. For the most part. Now, I think that this is where we suffer, though. I think we stay young as a profession because our turnover rate is so high. 5 years. Yeah, it's the typical seasoned medic now. 5 years in the seat. And when I say that, you can really see it now. The habits that some people pick up aren't the best, and they don't know it. They don't know a lot of times that what they picked up from their preceptor and continued through their career are not the best of habits. And so, and then we bring somebody out into the field, or sorry, from school to the field, and we put them with this person, and they're learning bad habits right off the bat. I really would, I would like to see that improve, where people where a preceptor was a competent person to start with,
Mhm.
maybe some type of way to see that person who carries the title of EMS preceptor would be competent, and then to be able to put a student, new paramedic with this person and get thoroughly precepted and where they would feel comfortable as a role as a paramedic.
I agree. I think a lot of that responsibility falls on supervisors.
Yeah.
Because as a supervisor, you should know your crews. You should know who you can put students with and who you absolutely should never introduce a student to. You should know that about your crews. And I think because of turnover and, that goes into a lot of other discussions about EMS, but because of whatever circumstances, supervisors don't have the opportunity to know their crews like they should, and students are put with whoever's available. Who can take a student today, who's not in trouble for their attitude or XYZ. They're going to get the student, and best of luck. You've got your 10 shifts, or
exactly.
Even the counties that are given 25 shifts, that's a lot of third ride time for a new medic.
Yeah.
But they're not turning out good medics.
Right.
I think a lot of that is because I think I know what you're talking about. Is they're precepting with people whose numbers are only 400 numbers lower than theirs, and they know nothing as well because they can't keep anyone.
Right.
Right.
It's not like they gave Tylenol through an IV to a child.
Oh my God. Oh my God. Wow.
You can give Tylenol IV, but we don't carry it on the truck.
Exactly.
Yeah.
It's very expensive.
Yeah, giving us
You only have it in the OR.
Yeah.
It's amazing. Like, that's another thing I wish we had pre-hospital was Tylenol IV.
Yeah, that would be awesome.
That would solve half of our narcotic problem.
Mm-hmm.
But that's another diversion right there.
Yeah.
Yeah.
Well, as for me, I appreciate you being on our show tonight.
Thank you.
We need to have you back again, very soon, because it was a great conversation. Happy Nurses Week. We appreciate what you do. Please tell everyone that you work with that we appreciate them. We totally get it that you guys have a hard job. The emergency department becomes overwhelmed. You run out of rooms. Sometimes there's nowhere to put the patient. Maybe your assignment is generally maybe 4 patients. Today it's 8. And I just want you to know from the bottom of our heart, we appreciate what nurses do, and we have enjoyed talking to you tonight.
Well, thank you for having me.
So
it has been a pleasure.
Pick of the week. Pat, do you have a particular pick of the week?
I do, Mike. I think you and Paige will like this, and Kaylee as well. This was just interesting to me. There's a fellow I know. He works for Jackson County EMS, and they're actually, I guess I don't really know, but I think they're kind of a rural area. I think he said they're a county of about 50,000. Are they very rural? I think they have like 50,000 residents, but they actually run I think he said 7 ambulances, and they have a pretty progressive set
they're
of
almost
protocols.
all medic.
Say it again, Paige.
They're almost all double medic trucks.
Oh wow!
Oh really?
They're all double medic.
Wow! I did not know.
I don't think.
Well, this is what. Yeah, that's impressive. This is what he mentioned to me the other day. He shared this with me. They are, and I haven't really processed this. I'm kind of 50-50 on this. you know, when you think about traumatic arrests,
Mm-hmm. you
say, I don't even know if we really work them that much, you know, unless it's something we witnessed. You know, a lot of times we come across a person who's in cardiac arrest secondary to blunt or penetrating trauma, and we go, yeah, this person's, you know, DOA.
Mhm.
They're making this big commitment to work almost all their traumatic arrests. A person found in cardiac arrest secondary to trauma, unless it's something like, it's basically someone from the neck down, blunt or penetrating trauma from the neck down, they're working that arrest. And the rationale behind it is not, you know, we're going to, you know, maybe save this person, but it's based on organ donation. And they actually have a protocol, and this was something that really struck me. It said, we may not save this patient's life, but we may save another patient's life. Very interesting. What are y'all's thoughts on that?
One or person can donate and save. I think their organs can go up to like 12 different people.
Wow.
And then you can donate skin and eyes and tissue, meaning ligaments and bone and all kinds of things. Almost all of our body can be donated to another person. So what good does it do to anybody to leave a person dead when we could try and potentially save 12 lives and impact hundreds of others from tissue donation? Yes. I absolutely agree with it. Go ahead and try. If anything, you've got a cool story to tell your buddies back at the station.
Yeah. Yep. I'm glad you were here for this, Kaylee, because it's something you might answer. I don't have the answer to. Like, if a person is in cardiac arrest and we're attempting resuscitation, I'm trying to think the right way to answer this. How long can tissue live, I guess, is the best way to say it. I mean, how long do we have to keep tissue, like skin, perfused before it's no longer any good?
So tissue, organ donation is really cool, and LifeLink has a really, really great presentation on organ donation that I think that they will go out to services and do for free. I know we did a clinical there one day at the bank in Georgia. So for us on the hospital side, there's actually a state law that says when a patient dies in our facility from whatever cause, we have an hour from the time of their death to the time that we can call LifeLink, because they can make the determination of whether or not a patient is a viable candidate for donation. If they are brain dead, but not clinically dead, meaning their heart is still beating, but they have no brain activity, that's when they can donate other organs, such as their heart and lungs, liver, kidneys, all of those things.
Okay.
But if they are clinically dead, we have pronounced them dead, we are not perfusing their body anymore, it can be days before tissue is harvested, because they're not harvesting blood vessels and those kind of things. It's not a tissue that has to be alive. For skin, when they're harvesting that, they're making it into skin grafts. So it doesn't have to perfuse. Most of our skin is dead anyway. They're not having to perfuse the skin. They're using it as wound coverage until the patient's skin regenerates itself. They're completely depleting all of the DNA out of our bones and ligaments and those kind of things, and repurposing it to create orthopedic devices for patients. So it's really interesting what all they can do with our body afterwards. We just have to give them a chance to do it.
Fascinating. You know, Kaylee, I'm sorry, I'm not trying to hog the last word.
No, I enjoyed it.
One quick question. This is just something I don't know, and I figured Kaylee probably knows the answer to this. How does that work as far as like consent and so forth? How does that play a role?
So, just like with any medical procedure, there has to be informed consent. The unique thing is that the patient can't be the one that gives their consent. So I have it on my driver's license that I'm an organ donor. That doesn't actually mean anything other than to tell LifeLink staff that they can tell the family your loved one made their wishes known that they wanted to donate their organs. This is what they wanted. They cannot take tissue or organs from a John Doe. They have to have consent from the next of kin. And it's really important for them to know that there's no financial burden or cost at all to a donor's family. There is, when we're harvesting a patient's organs, so they're brain dead but not clinically dead, all of their care from the time that LifeLink has determined that this is an organ donor and the family has given their consent, 100% of their care now is paid for by LifeLink. So that patient's medications and their treatment in the ICU and all of those things, that's not a burden on the family anymore. Oh, I just lost my train of thought. Crap.
LifeLink pays for it after.
LifeLink pays for everything after they determine that the patient is an organ donor.
Mm-hmm.
On the EMS side, and I think that's where patients are scared to put that they want to be an organ donor. I have never once looked at a patient's driver's license before I decided whether or not to work a cardiac arrest. That's a big fear is that they don't want to put that they're an organ donor because then they think the EMS is just going to let them die so that they can get their organs. That's not how it works. So that comes down to community education. And LifeLink really pushes that we're going to work you regardless of whether or not you're an organ donor. We're going to try to save your life, but if we can't, we want to save other lives too.
Absolutely. Absolutely. All right. Well, thank you for that information.
That was good info. Paige, pick of the week.
All right. So I'm going to turn the camera back over here. I know it is nursing week, but they also share it with Teachers Week. And since I teach full-time now, I would like to say I appreciate you, Mike, and myself, and everybody else out there who has taken on the role as
I appreciate y'all.
Students that students or learners look up to, admire, or want to learn from, and those who have a passion to teach others something else. Thank you.
That's awesome. Thank you, Paige. I'd like to give a shout out. My sister's a teacher. She teaches English, an English teacher in the Paulding County school system.
Where they learn to read.
What?
Where they learn to read.
Yes, me and my sister have this conversation quite a bit. And yes, so shout out to her. That was excellent. My pick of the week is going to be the FDNY. And we hear so much about the FDNY around our department, at least. But the FDNY named their first female EMS chief ever in their 154-year history. Lillian Bongsgone, I think is how she pronounces it. I'm not quite sure. I probably butchered her name, but luckily she probably won't ever watch this broadcast, so she won't know. But
There'll be a post tomorrow from her.
I know.
Yeah.
It's a weird thing.
She's also their first. She's also their first gay EMS chief.
That's exactly right. Yeah, and so I thought that was quite interesting. I'm glad to see that FDNY. I think that's good. I think they stepped up to the plate, and I think that we need to recognize that you know what, there's women that are equally have the same ability to serve in these roles as somebody else did, and I'm sure she's going to hear it was because she's a female or because of this or that, but I got a feeling that she was the most qualified applicant. And so that's how I feel. And so congratulations, Chief. I'm, proud that you made it. I know that was a hard struggle to make. Yeah.
Congratulations to her. Yeah.
Absolutely.
I came across just by happenstance. Thank you for bringing this up, Mike. It was a FDNY, their first all-female engine crew.
Oh wow! That's
the officer, driver, 2 tailboards.
Way.
Their first all-female engine crew. So yeah,
that's awesome.
Way to go, FDNY.
Way to go, man. Way to go. Go brothers. Around the cabin. Well, thank you again to our guests. Thank you to Pat. Thank you, Paige. Enjoyed this
Thank you.
this program, and I don't care if my mom's the only person that watches this. I enjoy the conversation. So
I love love it. Have a great time every week.
I do too.
Yeah,
Looking
thank you.
forward to next Wednesday.
All right, so Dino-Brains will be back on next week, same time, same place. So thank you guys, and I will see you. Paige, I'll see you tomorrow. Pat, I'll see you tomorrow. Kaylee, I'll see you when you come to teach right after you deliver.
All right, thanks, Mike.
All right, good night, y'all.
Good night.
Good night.